Okay, what about depression and the mini-gastric bypass? If you know, we talk about a lot of diseases that we treat with the MGB. So we expect, for example, osteoarthritis to get better, and sometimes remarkably better. And I think I told you yesterday about the patient who said that before surgery he was supposed to have an artificial knee replacement, and 6 months after surgery his orthopedic surgeon said your knee is better. And even though you're not supposed to, he told me that he was told that he had cartilage on the x-ray, which he didn't have before, which I don't think you're supposed to be able to do. So we think that the MGB helps osteoarthritis. We think the MGB helps high blood pressure and diabetes and sleep apnea and a bunch of things. So you might ask the question, what does the MGB do to depression? And the answer is, it varies. And it varies because depression has two major classes. And I'd like to talk a little bit about the different flavors of depression and then talk about the MGB's potential impact on the two types. One type of depression that's pretty well known is basically called situational depression. In other words, something terrible, something tragic happened in your life. You lost your job. You were in a motorcycle accident and we had to take off your leg. There are terrible things that happen in people's lives, and it's understandable. In some patients' case, they would be depressed about that. And that's a situation causes depression. Another kind of depression, though, is one where your life could be great. You have a wonderful family, you got a job, you're fabulously wealthy, you're a TV star. I mean, even if everything's going great, some of those people are depressed. That's what's called clinical depression or non-situational depression. Now, the clinical depression we think is kind of, maybe there's a chemical, serotonin, that's too low in the brain, or not enough norepinephrine, another chemical in the brain. So then you give different kinds of medicines for those types of depression, and they often help you get better. Okay, now let's go back and imagine our average patient. Our average patient is a 39-year-old woman who weighs about 300 pounds, who has diabetes and hypertension and maybe some other problems. Well, that's not the best situation in the world. To imagine carrying around that extra 150-pound backpack, to not sleep well, to be taking medicines that can maybe make you feel a little grumpy or tired. And so imagine then we do the MGB for the patient who has situational depression, who's depressed because of all those events in her life. She has to draw blood from her finger every day and check her blood sugar. She can't walk upstairs. She can hardly breathe. She can't play with the kids. She can't, do a bunch of things that would give joy in people's lives. And then we do the MGB and we take away all those problems. You can play with the kids. You can go hiking when you used to go hiking. We have people who take up kayaking and all kinds of great stuff. And they can do that now. If they had situational depression and we change the situation, then there's a chance that your depression would get better. Cool. The flip side, though, is if you were fabulously wealthy and successful and you had all these things and we do the MGB and we give you some more positives, it might be if you have the non-situational or clinical depression that you would continue to suffer from depression afterwards because we might not change the serotonin in your brain. So we have seen post-op patients with both kinds of outcomes. We've seen people where we change all these things, which externally look wonderful to me. If I was no longer a diabetic, it seems like to me I would be very happy, because diabetes seems like it's awful. If you never had to take your high blood pressure and your high cholesterol medicines, if your joint pain was less, it seems to me that would make sense, that would make you much happier. But we've had people where, even though they have everything, they're still depressed, and that's not a criticism of them. They may have an inadequate amount of serotonin or norepinephrine. They may have clinical depression. And in that case, the MGB, although it makes them healthier and better, may not make them happier. Now, if you have situational depression and we make those situations change, then if you're taking an antidepressant in 6 months or a year, it may be that you could come off of it. So we recommend to our patients that 6 months or a year after the surgery, they go back and talk with their psychologist or psychiatrist and discuss the use of their antidepressant to see whether or not it's appropriate to continue it or whether they might have had a situational depression. Maybe the situation has changed and reevaluate whether it should be continued. Does that make sense?
Good. Yeah.
But we never, what I'm trying to say is never stop it right around the time of surgery, because Effexor and a variety of the other antidepressants have a withdrawal syndrome, which is pretty awful. Mm-hmm. It's not quite as bad as withdrawing from heroin, but it's right next door. So don't stop it. We have people who say, I'm getting ready for surgery, and by the way, I stopped my Effexor and this and that. And you're going, don't do that.
Yeah, if I'm late on my dosage,
Yeah.
I get dizzy. For a while, I didn't realize I was missing my dose, and I was falling down a lot, and just.
That's a bad thing, right?
And I didn't know why I was falling down, and it was because I would forget to take my Effexor.
And that's nothing compared to if you wait a little bit longer, it gets much worse than the falling down. You get high blood pressure. You can actually go crazy.
Yeah.
To use a medical term. Okay, that's the medicines. Good. I think we're done with that.